Hello, this is Dr. David Green, CEO of the Mid-Atlantic Pain Network. Today's topic is what you need to know about epidural injections. An epidural injection is an outpatient procedure, involves placing steroid and numbing medicine into the epidural space. It's designed to relieve the pain from pinched nerves. The epidural space is the area around the spinal cord where the nerve roots come off at each level. The injection is not designed to go into either the spinal cord or the nerve root itself. So what are the indications for epidural injections? First and foremost, a herniated disc with radiculopathy or sciatica. So here we're looking down at a disc that has a large disc bulge and a herniation, and it's pushing on this nerve root as it comes off from the spinal cord, and it leads to inflammation and pain down that nerve root. Spinal stenosis is a great indication for epidural injections. Spinal stenosis is where arthritis or soft tissue overgrowth pushes on various nerve roots, and that usually occurs at several levels. So an epidural injection can help a lot. A tear in the outer part of the disc is called an annular tear. There are nerve endings in the outer part of the disc that can spark up inflammation and sciatica. Compression fractures can also benefit from epidural injections. There are three different types of epidural injections. The most common, the one that was invented back in the 1960s, was an interlaminar epidural injection. It's called that because these are two levels of the spine. This is a lamina. This is a lamina as well. Those are parts of the spinous bone, and basically the area between them is called the interlaminar space. That's where the needle goes. When they first invented this, they really didn't have fluoroscopy, which is the real-time x-ray. So what they would do is they would go into this ligament area, and then they would do a technique basically called loss of resistance, where you have this resistance from the soft tissue, and then you lose it, and you know you're in the epidural space, okay? Transforaminal epidural injection is the latest invention, and basically what happens here is you're not going interlaminar, you're actually going where the nerve root comes out from the spine, and that's called the foramina. So basically the needle goes into this area, where is actually where most disc herniations occur and where the pinching is. So you're putting the medication much closer to the area of actual pinching. Caudal epidural is a different beast, altogether. What you're doing is the pain doctor is putting the needle into this area at the very, very bottom of the spine called the sacral hiatus. Okay, the needle goes in, a large amount of steroid and numbing medicine is placed. It migrates up into the lumbar spine, and it can cover multiple areas. This is great if you have spinal stenosis and you have multiple areas getting pinched. If you've had a previous spinal fusion and the needle is tough going through some scar tissue, this can be a great technique. Well, how are they performed? Epidural injections are an outpatient procedure. It takes about half an hour. Maybe the pain doctor uses sedation, maybe not. Could be just local numbing through the soft tissues. Real-time x-ray is typically used by modern pain doctors. It's called fluoroscopy. For interlaminar, there's a loss of resistance technique, which I mentioned. Once the needle is in the desired positioning, the pain doctor will inject some dye to make sure it's really accurate. And then afterwards, the patients go home the same day within about an hour. How well do they work? There have been dozens of studies looking at epidural injections. The best ones showed 75 to 90% good to excellent results. The person may need a series of 3 injections over a 6-week period for the maximum benefit. The numbing medicine kicks in right away. The steroid may take 2 to 3 days to actually kick in, and then it can last for a few days to a few months, and then it can be repeated. What are the risks of epidurals? Well, there are some small risks. There's a risk of infection. There's a risk of some bleeding. The person should stop anti-inflammatories a week or so beforehand. There's a risk of an allergic reaction, some temporary side effects from the steroid, such as water retention, blood sugar transient increases. It could be a nerve injury. That's a serious complication. It might not work. The complication rate overall is over 1%. Epidural injections are not FDA approved for use in the spinal canal. This isn't necessarily a bad thing. I mean, medications are used all the time for off-label indications, effectively. It's legal, it's often beneficial. I think it's like 40% of medications are off-label being used. Here's 3 examples real quick. Neurontin is FDA approved for anti-seizure, but it's used all the time for nerve pain and migraines. Lidoderm is FDA approved as a skin patch for shingles, but it's used off-label all the time for back pain and other pain-relieving needs. Propranolol is FDA approved for high blood pressure, but as a lot of people know, it's used off-label for performance anxiety frequently. The top non-operative pain management in the Mid-Atlantic region is through the Mid-Atlantic Pain Network. There are many clinics throughout the area, Maryland, Virginia, and surrounding states. Over 50 insurances are accepted, with over 25 treatment options being provided by the board-certified, award-winning doctors. Visit us online today at midatlanticpainnetwork.com, and then call us for more information and scheduling at 855-444-6585. I'm Dr. David Green with the Mid-Atlantic Pain Network. Your pain stops here.